in. So for this session, I would like to invite a chairperson, that is Dr. Rishi Mohan from Delhi. I take over this session. I would request Dr. Rishi Mohan to take over this session. Thank you so much. Welcome once again.
Thank you, Tanvi, and thanks to the scientific committee of the AIOS for having this course. I would welcome my faculty who are joining in one at a time. I see Rajiv Mukherjee, so I welcome him, and Dr. Vanati, welcome. And we will have the other faculty joining as soon as they have the the opportunity to join. They're all busy with other courses simultaneously. So we have some instructors and some floating instructors. So the floating instructors will join as and when it's possible for them. So we have the honor of having Dr. Honching Ong, who is our guest speaker for this evening. And Dr. Honching Ong is going to be giving us a keynote address on the subject of the clinical monitoring of conjunctival scarring. Dr. Ong is from the cornea consultant at the Singapore National Eye Center. He obtained his medical degree from Barts and the London School of Medicine at the University of London in the UK. In medical school, he was awarded a total of 16 prizes and awards, the highest number achieved by any individual in his alumnus. Congratulations. And he has an overall best in his cohort and was a Proxime Asset to the University of London Gold Medal. So I welcome Dr. Honching Ong, and over to you for your keynote address.
Good day. I'd like to thank Dr. Biswas and the AIOS Scientific Committee for the invitation to give this talk. I'll be presenting something new that we've been working on in Singapore over the past 2 years. Corneal scarring can be caused by a variety of insults to the cornea, including infections, inflammation, or corneal dystrophy, and it's a leading indication for corneal transplantations. However, there's a fundamental limitation with current corneal transplantations. The number of transplants is limited by a global shortage of suitable donor corneas. A global report indicated that only 1 in 70 of the overall needs of corneal transplantations are met. Some reasons include low endothelial cell count or lack of availability for serological testing. The utilization of donor cornea is such that 1 donor is used for 1, 2, or at most 3 recipients. Other problems with transplantations include high surgical expertise and cost, the long visual rehabilitation process for some transplantations, and the risks of immune rejection and graft failure. With the limitations of transplantations, there is thus a drive to search for alternative, more scalable treatment modalities to meet the global demands for corneal transplantation. Such modalities must be less reliant on donor tissues, are less invasive, and technically less challenging. Current research focuses on 2 main areas: regenerative medicine, where cells are made to regrow or repair to replace diseased cells and thus restore physiological function, or scalable options such as cell-based therapies. The majority of transplants are performed for corneal endothelial diseases, followed by stromal diseases. As mentioned, the 2 areas of potential therapies for corneal diseases are regenerative medicine and cell-based therapy. I'll be presenting our preliminary work on the use of mesenchymal stem cells-derived exosomes as potential therapies for corneal scarring. Mesenchymal stem cells are multipotent progenitor cells that originate from the mesoderm of many tissues, including bone marrow, blood, liver, spleen. They have a capacity to self-renew and ability to regenerate differentiated cells. Due to the potential role in regenerative medicine, immunomodulation, and neuroprotection, and anti-tumor effects, the use of mesenchymal stem cells as a therapy have emerged as a popular research topic in recent years. Their effects have been originally attributed to direct cell replacement. However, studies have reported that MSCs are mostly cleared, while a small proportion will integrate into injured tissues after intravenous injections. Various hypotheses have been suggested with regard to the mechanism underlying the therapeutic potential of mesenchymal stem cells, and these include the transfer of mitochondria or exosomes, packaging a wide variety of different molecules. Exosomes originate in the endocytic cycle, and early endosomes experience inward budding and form intraluminal vesicles where they develop into late endosomes or multivesicular bodies, which may either fuse with lysosomes for degradation of content or fuse with the plasma membrane to be discharged to the extracellular environment. And these extracellular vesicles are the exosomes. They are a family of nanoparticles between 30 to 100 nanometers. And they're thought to be enriched with endosomes-derived components and many bioactive molecules, including protein, lipids, and nucleic acid components. As they are released from multiple cell types, this suggests that the secretion of exosomes is a general cellular function important in the intercellular transfer of information. In recent years, the therapeutic potential of mesenchymal stem cells-derived exosomes have been investigated for systemic diseases including liver, cardiopulmonary, and neurodegenerative diseases. Various preclinical studies have also showed the potential therapeutic effects of exosomes in ocular diseases. For corneal diseases, research into exosomes from various cell sources have been used, including corneal stromal stem cells, corneal stromal mesenchymal stem cells, and umbilical cord mesenchymal stem cells-derived exosomes. We hypothesize that topically administered human mesenchymal stem cells-derived exosomes can alter corneal wound healing and modify the density of corneal opacities. Our exosomes came from our collaborators at A*STAR Institute of Molecular Biology in Singapore. The exosomes were collected from the conditioned media of human embryonic stem cells-derived mesenchymal stem cells. They were then concentrated and fractionated to yield the exosomes of 1 milligram per liter conditioned media of 10 to 11 cells. They were assessed for characteristics exosome markers such as CD9 and CD81. The first step is to evaluate the optimal dosing frequency for topical exosomes. Alex-Flor labeled exosomes were topically applied to normal rat corneas in epithelium-on versus epithelium-off models. For distribution and dosage intensity studies, confocal laser ophthalmoscopy was used to assess the time-lapse tracing of labeled exosomes. Topical administration of labeled exosomes to epithelium-off models showed signals retained for 24 hours and a time-dependent clearance with a half-life of approximately 3 hours. Exosomes applied every 3 hours maintained signal over 50% peak intensity. In contrast, there was a rapid signal disappearance of less than an hour was observed in epithelium-on corneas. Having established an optimal dosing frequency, we moved on to evaluate the effects of topically applied exosomes to our established rat stromal haze model. Stromal haze was induced using irregular PTK or phototherapeutic keratectomy, and exosomes were applied 6 times a day, which is every 3 hours, and normal saline were used as controls. We used this stromal haze grading scale to assess the degree of scarring. Rat corneas develops haze within the first week following PTK and takes around 3 to 4 weeks to reach peak levels. And this experiment targets the early haze development period. Corneas were significantly clearer in the exosome group compared to control saline group. We also observed less corneal neovascularization in the exosome group. By quantifying these vessels, we showed lower vessel length, percentage quadrant of involvement, and area of vascularization. Immunostain also shows less angiogenic markers expressed and significantly lower vessel width compared to controls. This shows that application of exosomes have an anti-angiogenic effect following corneal injury. There was also less expression of fibronectin in the exosome group, which may suggest a dampening of the fibrotic response. There was also less expression of COL3A1 and alpha SMA in the exosome group, which are markers of myofibroblast differentiation. Flow cytometry also showed a lower number of alpha SMA expressing corneal cells. Thus, we have demonstrated the anti-angiogenic and anti-fibrotic effects of topically applied exosomes in our injury model. Assessing the excised rat corneas at day 5 postoperatively in the exosome-treated group, there appears to be a higher CD163 to CD80 ratio. This indicates a more significant state of anti-inflammation or tissue repair when exosomes are applied, suggesting an immunomodulatory effect of the extracellular vesicle. In conclusion, we showed that topically administered embryonic stem cells derived human mesenchymal stem cells derived exosomes are potential therapies for corneal opacities. We've established an optimal dosing frequency for topical exosomes. The corneal epithelium appears to impede exosome permeation. However, prolonged effects on epithelium on cornea still needs to be established. The permeation of topical exosomes also needs investigations, and it may be that stromal injections may be more suitable for deeper scars. We showed significant suppression of corneal neovascularization, stromal fibrosis, and inflammation. Currently, we are performing ongoing studies to understand the mechanism of action of these exosomes, which is the attributes of the exosomal cargo. The differences in therapeutic effects of other cell sources of exosomes is largely unknown, such as those derived from corneal stromal stem cells or other mesenchymal stem cells. I'd like to thank Professor George Mehta and his Tissue Engineering and Cell Therapy group for this work. Thank you very much.
Can you allow me my video, please, Tanvi?
So I have sent you the request.
Yeah.
On है sir वो तो.
It's on, sir. You are visible.
Yeah, I know. It's just come on. All right. So thanks so much, Dr. Oncheng. It was a very nice presentation, and I thank you for being with us and for enlightening our listeners and our attendees on the scale and the quality of your work. So I thank you for being a part of the AIOS on behalf of the scientific committee.
Thank you once again for the invitation to speak. Thank you.
Thank you. Thank you so much. We're going to move on now to the rest of the meeting, and I'm sure that we're all looking forward to this. So I'm going to start by sharing my screen and coming up with just the first couple of introductory slides. And so you know that we're going to be talking about the confusions, the concerns, and the changing paradigms. It's a course that we've been doing for some years now, barring a couple of years in between. The faculty is our past masters at this from all across the country, and we'll be introducing them as the course proceeds. Where is the... So this is how the course is constructed. We're going to start with just a couple of slides on the dues to and what is new with COVID-19. This course is known for the fact that it modifies its content each year based on whatever is new and whatever is happening. What's troubling your patient is going to be addressed by Dr. Quresh Muscati, who is not here physically, but he's been kind enough to send us his slides and his talk. The OSD Masquerades by Dr. Umang Mathur from Delhi. I will be taking up hyperosmolarity and osmoprotection, and this will be followed by Professor Vanati from the RP Center, who will be telling us about how to choose the appropriate artificial tears, and meibomian gland dysfunction by my colleague, Dr. Rajiv Mukherjee from Delhi. Professor Rajesh Sinha from AIIMS will tell us about post-surgical dry eye disease and the new molecules, chloroquine, lifitegrast, and ribamipide, and cyclosporin, which has now come to stay as an important molecule in our management of inflammation, is going to be again taken up by Dr. Vanati. And finally, Dr. Rohit Shetty from Bangalore is going to be telling us about inflammation and dry eye and the role of vitamin D and his work specifically, which is phenomenal. So just to get onto the definition of DEWS, which was given by DEWS of dry eye, It's a multifactorial disease. It involves tear film instability and potential damage. There is hyperosmolarity and inflammation of the ocular surface. So this was the 2007 definition. And in 2017, what has changed in this definition? So one can see that multifactorial disease is still there. There is tear film instability, hyperosmolarity, inflammation, and damage, which is still there in the definition with the presence of ocular symptoms and visual disturbance. But the loss of homeostasis of the tear film and the addition of neurosensory abnormalities which play etiological roles has been added. So this inflammation, hyperosmolarity, and tear film instability, along with other factors, was the part of the key events that were happening to perpetuate or to create a dry eye. And now, of course, it's become far more complex, with asymptomatic and symptomatic patients being added, those with signs and those with symptoms only. And at the end, there are people like people with neuropathic pathologies, with pain, which are the newer understandings, the neurotrophic conditions with dysfunctional sensations. These are the new things that have been added in the definition, and the spectrum has become much wider and far better now than it was a decade ago. Just a slide on the impact of COVID, and I thought this was appropriate. This has led to an increase in the prevalence of dry eye disease, especially amongst the younger people. There's an increased screen time with excessive evaporation of tear fluid. There's prolonged blinking and intervals, and there is a lot of gazing. Studies have shown that an hour of tablet or smartphone use increases the eye strain and the blur by as much as 5 times. The other potential issue has been the widespread use of face masks, which adds another dimension to the whole thing. So the displacement of the mask or an incorrectly fitted mask will disperse air around the eye, and this air leakage and flow adds to what we call MADE, or mask-associated dry eye disease. So I'm going to go on now and go to the next speaker, who is going to be Dr. Quresh Muscati, and I'm going to continue to share my slides and go ahead and present his talk.
So I guess the speaker which you have called is not present.
Yes, so Dr. Quresh Muscati's slides I'm going to present. He's
Okay.
got his whole talk here, and so I'm going to be presenting that.
Thank you, Rishi, for inviting me to this IC.
Can you hear me?
Today
Can
we
you
will
hear him?
discuss what is troubling your patient.
Sir,
It's
Allergy,
perfect.
Infection, dryness, or a combination of these. Rishi, since I'm not with you, I request you to change the slide whenever I say next. Next. My financial disclosures are obviously none. Next. So it's easy when the features are classical, like in classical allergy that you can see here, giant papillae on the palpebral conjunctiva. The limbus is studded with the Horner-Trantas dots and the limbal variety of spring cuttard that you can see in the other pictures. So when it's classical, there is no difficulty in distinguishing that this is pure allergy. Next. Also in pure conjunctival infection, the pink slide that I've selected is from my father's collection of 50 years ago to show that simple conjunctival infection or conjunctivitis has not changed in appearance, in clinical appearance since my father's time. There's no ciliary flush, there is conjunctival congestion, mainly the fornices and far away from the limbus. You can have mucopurulent discharge, as you can see in the other slide, and it could be part of an epidemic with bilateral involvement. So pure infection, again, a no-brainer. Next. Also pure dry eye patients, the computer vision programmer with infrequent blinking that you can see, the meibomitis looking obvious, squamous blepharitis with the dandruff or scales that you can see. And if you do any test like the Sherman's test, it comes very little amount of wetting, classical rose Bengal staining, or a reduced breakup time. So these are classical dry eyes. You don't have to wait till you see filamentary keratitis to diagnose a dry eye. So this is again the classical dry eye. Next. Let's What about mixed issues? What about a patient with allergy and dry eye? Is it possible? Yes, of course it is possible. How do you diagnose it? Use your ears first, not your eyes. So careful history. Patients of allergy will complain of itching sensation. Is the patient also complaining of a sense of burning sensation or a sandy feeling or a foreign body sensation along with the itching? Perk up your ears. It could be a dry eye in addition. How do you confirm this? Simple. Just do a therapeutic trial, add preservative-free lubricants to the allergy treatment. Is the patient significantly better? If so, that means your diagnosis of a mixed allergy plus dry eye was correct. Next. Let's talk about conjunctival infection a little bit. Most cases are viral, don't need heavy topical antibiotics. Just because the medical rep came to you and promoted the oxyfloxacin or higher strength catafloxacin, you don't have to use it on poor unsuspecting conjunctivitis. A simple lubricant will be enough, or if you must give something, you can use something as simple as chloramphenicol or polymyxin or the lowest possible antibiotics. And don't overtreat. If you treat it for 4 to 7 days or 10 days maximum, it will improve. If it is not improved, it is not a bacterial conjunctivitis. If it is worsened after initial improvement, suspect conjunctivitis medicamentosa. Immediately stop the antibiotic drops. No tapering, and replace with non-preserved lubricants. Frequent use. Patient should feel better within 48 hours. If so, then you are dealing with the medicamentosa and you can gradually add surface acting steroids to the lubricants. Next. So beware of this. The classical picture of a keratitis or a conjunctivitis medicamentosa. If cornea is involved, keratitis. If not, it's conjunctivitis. You get a foggy, chemotic conjunctiva. And of course, plenty of symptoms and signs. Next. So symptoms will be initial, typical. This is initial improvement in the original condition. Perhaps there was a conjunctivitis. It improved with your antibiotic drops. Then there was a deterioration. Despite your increasing the antibiotic drops, then worsened ocular pain, stinging, burning, photophobia, and in signs you saw fogginess of the lids, fogginess of the conjunctiva, some blurred vision. If it is medicamentosa of the cornea, keratitis medicamentosa, then you could see SPKs or even epithelial defects could be there, and dilated vessels like you see in the picture on the right of long standing. And a follicular type of conjunctival congestion could be there. Sometimes you could even see pseudodendrites. So beware of this condition and to diagnose it. Next. So dry eye plus infection can most certainly coexist. It's not uncommon. Don't forward to the topical antibiotic treatment, otherwise you push him into medicamentosa. So again, add topical antibiotics, but remember that topical antibiotics, especially aminoglycosides, like gentamicin or tobramycin, are toxic to the surface in dry eye and can worsen the dry eye. Hence, treat aggressively for a week or so and then abruptly stop the antibiotics, but don't forget to continue the lubricants. Next. What about allergy and infection? Of course, they can coexist. Remember, most of your allergy patients are children. They love playing with animals who are dirty. They love playing with other children who are sometimes even dirtier. And they often rub their eyes with dirty fingers. So suspect a coexisting infection. If the parent tells you on the phone that the eye discharge is different, call the patient in and look for coexisting infection besides papillae. If the rest of the conjunctiva is also looking red, then a short course of frequent topical antibiotics is required. But let the allergy treatment continue. Don't stop. Avoid aggressive steroid therapy in diagnostic dilemmas. I told you things can coexist. So please don't use steroids because they suppress all symptoms, but they might even cause a fungal infection and even a fungal corneal abscess sometimes. And avoid shotgun therapy with multiple anti-infective agents. So if it's a red eye, you add antifungal, antiviral, antibiotics, steroids, the works. These are a sure recipe for conjunctivitis medicamentosa. Next. To conclude, allergy plus dry eye or infection plus dry eye or allergy plus infection can most certainly coexist. Learn to recognize and treat these. Avoid telephonic diagnosis and treatment of chronic dry eye or allergy patients on the phone. Don't over to anti-infective treatment. You can cause medicamentosa. Do not taper topical antibiotics, and beware of conjunctivitis or keratitis medicamentosa. Next. I hope I have removed some of your cobwebs and made things a little clearer. The things can coexist. No shotgun therapy, no overdoing steroids, and avoid medicamentosa. Thank you so much for your attention.
Well, thanks to Dr. Quresh for sending that very lovely voiceover and that set of slides. And he's brought forward the differential diagnosis of dry eye. We're going to move on to Dr. Umang Mathur, who is my colleague and senior consultant and the director of cornea at the Shroff Charity Eye Hospital here in Delhi. And he always has a wonderful knack of looking at a problem in unique ways. So he's going to tell us about the OST masquerades and telling us how not to be distracted by those.
Yeah.
Umang.
Yeah, thank you so much. It's always a pleasure to be part of this course. And I just pull my slides up. Yeah, so I'll be talking of some of these interesting cases that we overlook in our clinics. This was a 50-year-old female presented with pain, redness, watering. Apparently was all right a month back, accidentally put some Ayurvedic balm in her eye and was getting treated as a bacterial ulcer with a lot of drops with no relief. And this is how she presented, with an epithelial defect and thinning and vascularization. What are we dealing with? If you look at the fellow eye, all our attention actually went into this eye with the history of something falling into the eye. If you look at the fellow eye, it was stained with SPKs, and probing a little deeper, she had multiple joint pains, morning stiffness, and typical history of rheumatoid arthritis, and she was not on any treatment for the same. Further investigations proved her to be suffering from rheumatoid arthritis, subsequently underwent tissue adhesive. And a similar case, this was another patient who presented to us post-cataract surgery 20 days prior with an epithelial defect and clean base, complaining of pain, redness, irritation after cataract surgery. What's the fellow eye status? It was an empty socket. What had happened in this eye? Had a cataract surgery 6 months back, again had keratitis and was eventually eviscerated. The patient was on a cocktail of antimicrobials, and on further in history, we found the patient again had joint pains, small joints, dry mouth for a few years. And this was again a patient of rheumatoid arthritis who had been left untreated, and the surgical trauma led to the sterile corneal melt. Subsequently, with DMARDs, the patient recovered and finally had a 636 vision. This is another patient presented with a history of female, 55-year-old with pain, watering for 1 month duration, had epithelial defects, scleritis, and this infiltration in the periphery. Case of PUK, on investigations, her C anchor was raised, and that was an indication for this disease to be associated with Wegener's granulomatosis. Further investigation also found that she had upper respiratory tract issues, and the patient was put on immunosuppressions. And finally, the patient healed with thinning and scarring, eventually underwent a phacoemulsification after several weeks after the patient was stabilized. However, the disease did get reactivated after surgery. So a lot of these patients do require systemic evaluation. And as ophthalmologists, we have to remember that the disease is not just in the eye, and we have to look further. and we need to look at their systemic conditions, get their blood investigations, and the answer may lie in systemic problems. This was a 52-year-old gentleman who complained of persistent redness, discomfort, watering after a cataract surgery. As you can see, the patient had meibomian gland disease. And on our Indian skin, sometimes it's not very easy to discern, but basically this patient was suffering from rosacea for several years. On this Westerner, much easier to tell, and complained of multiple chalazion appearing at different times in his life. And on the Caucasian skin, of course, it's much easier to tell, and he is still having rosacea. I think in India, a lot of it remains misdiagnosed. The new association of rosacea is with Demodex, and here's a series of interesting patients we have. This was a young patient, had 618 vision and 15-year-old in 2011. In the left eye, 6.9, florid vascularization, recurrent inflammation, like marginal keratitis, various diagnoses, various treatments he had received, and it was worsening. The patient was even put on immunosuppressants, needed Boston scleral lenses for his vision. And it continued to progress. And of course, the patient was frustrated and depressed. And also the doctor treating doctor, myself, extremely distressed as the condition. Till we learned what it was. It was basically, we pulled out a few lashes and we see this mite under the microscope. And since then, we've been diagnosing several patients with Demodex, and it's quite common to see. Most of these patients, a lot of them are young, with good hygiene, and we've variously been treating them as PUK, Tyrians, even acanthamoeba keratitis, and we found a lot of them were actually Demodex. And Demodex mite can easily be seen by plucking the eyelashes and then seeing under the light microscope. And you see this creepy mite moving around. It's treated with tea tree oil and ivermectin. Yes, the same ivermectin being used for COVID. And this is a condition I think we today need to keep in mind. And we have this paper in IGO recently on our case series. This patient complaining of photophobia and a lot of SPKs. And you realize that this is essential blepharospasm. I think my video is not working. And essential blepharospasm could be the cause or the effect. Another young patient who had a history of alcoholism, drug abuse, having ulcers in the mouth and stomach, and presented with this epithelial defect, very dry looking conjunctiva. I'll just finish. And further investigation, we found ultimately needed a keratoplasty. Didn't know what we were dealing with till we got a physician opinion. And this was actually a case of malabsorption and vitamin A deficiency. So as we've been discussing, dry eye is a multifactorial disease, and one has to look at systemic issues as well. And a lot of these diseases can be confused, and we need to keep an open mind to find the diagnosis. Thank you so much.
Thank you, Umang. As always, you've done great justice to this talk, and you've given us all these new ideas. We will, of course, have questions for you. I'm sure there are who have questions for you, and we will take them all up at the end. So we're going to move on to the next presentation, and the next presentation is going to be on osmolarity and hyperosmolarity. And I'm going to try and see if I can set this up. Right. So can you see my slides? Hello?
Yes, sir. Yes, sir. We can see
Yes.
your
Okay,
slides.
great. Right. So we're going to go on with the talks, and we're going to now talk about the two aspects, or at least the one aspect that was there in the definition that we had enunciated earlier, which was the impact of hyperosmolarity. So what happens? Is there really any hyperosmolarity? And is there a role of trying to protect us from this hyperosmolarity, which is what we call osmoprotection? I don't have any financial disclosures here. So as we all know, that the vicious circle of dry eye disease has tear film instability, hyperosmolarity, inflammation, and apoptosis as the key events that perpetuate this cycle. There are various extraneous factors that impact this, which are all enunciated in this. This chart is now a familiar chart that we all see, with hyperosmolarity being one of the key which initiate the whole process. So the osmolarity of the normal tear film is between 296 and 302 milliosmoles. But in dry eye disease, this value is generally much higher at about 316 to 360 milliosmoles. It is estimated that over the central cornea, this may be much higher because there's a very, very thin tear film in that area, but that's not where the samples can be collected in clinical practice. So osmolarity is important because when the proportion of water to the solutes in both the tear film and in the cell are the same, the system is said to be in an isotonic state. But when there is evaporation and there is a hypertonic environment, the cells lose water, and this causes them to shrink as they become dehydrated. But as you understand, a tissue cannot really shrink. So it has to retain its own volume. And so the cell undergoes what we call regulatory volume adjustment. And it does this by introducing or imbibing salts. And along with the salts come in the water, which restores the volume. However, the salts are metabolically active, and they decrease the cell function and cause stress activation, which then leads to cell damage and cell death. This ocular surface damage starts fairly early in the whole process. And on day one, there can be dry eye and hyperosmolar stress with stress kinase activation and transcriptional activation leading to acute epithelial disease. And by the end of the week, we enter into phase 3, wherein we now get a chronic ocular surface damage because of the influx of the cell-mediated inflammation or the T cell cytokine release. So this is the timelines on it. So what happens? Can we actually reverse this whole process against hyperosmolarity? Can there be some other compensatory mechanism? Yes, there can be. And we can offer these cells of the corneal and conjunctival epithelium the option to use or employ or import compatible solutes, which leads to a regulatory volume increase because it comes coupled with water, and the restoration of the cell volume happens. But these osmoprotectants or compatible solutes, which are taken up by the cells, do not interfere in the cell metabolism. They will restore cell volume and stabilize protein function without any negative effects. So these compatible solutes are small non-ionic organic compounds that build intracellular osmotic strength without damaging proteins. And osmoprotection is the process by which the cell functions without this damage. Numerous tissues in the body have this capacity or capability to either synthesize or import these compatible solutes, but not so lucky is the corneal epithelium. So let's look at a couple of lab studies and seeing the effect of the compatible solutes on hyperosmolar stress in corneal epithelial cells. So human corneal epithelial cells, which show the phosphorylation ratios to the total amount of MAP kinases as a result of hyperosmolarity, are substantially protected when the media introduces L-carnitine and erythritol, which are the osmoprotectants. Similarly, clinically, there is a superiority of osmotically regulated tear preparations over passive tear substitutes. And if we look at desiccated corneal epithelium, we find that the rehydration of the epithelium occurs very nicely in the cells which have been exposed to an osmotically regulated tear preparation. If we look at osmoprotectants and their impact on mRNA expression and protein production enzymatic activity in cells or human corneal cells which are exposed to high osmolarity, one can see that as the osmolarity goes up, the expression of these enzymes goes up, but in the presence of these protectants, the expression of these enzymes is substantially reduced. Some clinical evidence too exists where there's a comparison of the osmotically regulated preparations as compared to others. We can see the mean OSDI scores and the mean number of drops being lowered. We can see the switchover studies of a very large series of these patients, and they all reported improved comforts and improved clinical signs and symptoms with an improvement in tear breakup time significantly from baseline. There are other evidences again of these osmoprotectants becoming extremely useful. Here we can see patients who have dry eye have a substantially reduced amount of L-carnitine levels in the tears of patients, and this opens up the possibility of therapeutic uses of these products. So here are some of the osmoprotectants that exist in nature. L-carnitine, erythritol, glycerol, and trehalose are some of those that have been used now in ophthalmic preparations for dry eye. So to restore homeostasis, one has to protect against hyperosmolarity. There's an expanding pool of clinical data that suggests that there is a role of osmoprotectants. This osmoprotective effect depends on how much osmoprotectant the cell takes up and how long it is retained. So there are small osmoprotectants, which are smaller molecules, which leave and enter very quickly. And then there are larger ones, which require the amino acid transport for an active ingress and egress into the cells. So there's glycerol, which is very rapidly introduced and extruded. Erythritol, slightly larger molecule, which can passively diffuse in and diffuse out as well. And then L-carnitine, which has to be actively transported. And it is the ideal combination of these osmoprotectants with different kinetics, which may work better to increase the overall protection in dry eye. So conventional therapies only help at the surface, whereas the osmoprotectants tend to neutralize the hypertonic state and increase the tear retention time and improve the osmoprotection that is possible. So in summary, dry eye produces significant ocular surface damage mediated by hyperosmolarity, which is a key mechanism in the evolution of dry eye, and cells utilize short and long-term regulatory mechanisms to maintain the osmotic balance. Hypotonic solutions provide only very transient relief. So compatible solutes, and if they are provided in these tear formulations that we have, help regulate the osmolar balance and reduce the stress and restore the homeostasis and the tear film osmolarity. So incorporating compatible solutes with different kinetic properties in artificial tear substitutes may be more effective in protecting our patients. So thank you so much for that patient listening. To stop sharing my slides, and I'm going to now request Dr. Vanati, who is the professor of in the cornea department at the RP Center in the All India Institute of Medical Sciences. I'm going to request her to give us her talk on what she suggests is the best way to approach the choosing an appropriate artificial teardrop.
Thank you, Dr. Rishi. Am I audible and visible?
Yes, Vanati.
Thank you, sir. And for the next 7 minutes, I'm going to take you on what is the optimal artificial teardrop you would like to choose for your patient. No financial interest in the mention of any of the products during the course of my talk. So this is what all physicians, all clinicians face when they look at the battery of products which are now available over the counter for managing dry eye disease. Which one is going to be more optimal? We've seen this vicious circle chart in almost every talk of dry eye. Remember, when you're looking at artificial replacements, artificial tears are not targeting the pathogenesis of the dry eye disease, but are tailored to produce symptomatic relief, stabilize the tear film, and to a certain extent tackle the hyperosmolarity. So that's what's going to be the mechanism of action. And in today's approach to dry eye disease management, we have moved away from managing symptomatic dry eye to managing or stabilizing the tear film to produce an optimal tear homeostasis so that you do not have progressive damage to the ocular surface. So that's how the approach towards management of dry eye has changed. And understanding the tear film model plays an imperative role. So it's a complex model of superficial lipids and a mucin aqueous combination lying underneath. The lipid layer is a mixture of polar and non-polar lipids, where the aqueous mucin has a complex integrated structures of soluble proteins and mucins and the glycocalyx layer, which is closely integrated with the epithelial cell microvilli. So why do we need artificial tears, or how do they actually help us? They form the first line of therapy, and they help in tear volume replenishment, the stabilization, provide a smooth refractive surface, help in reducing the tear osmolarity, and protect the ocular surface from damage due to the friction between the ocular adnexa. What do they contain? They have demolissants and emollients. So basically, they have an active ingredient and an inactive ingredient. The active ingredients are demolissants, which are water-soluble hydrogen polymers, which could be either cellulose-based, or they could be a PEG-PG combination. And they help to increase the tear viscosity, and there are varying concentrations in which used, and emollients are basically lipid-containing formulations, which would increase the surface retention. What are the inactive ingredients? These largely comprise of preservatives, buffers and electrolytes, osmoprotections, and viscosity enhancing agents. So understanding what your teardrop contains is going to go a long way in what you would probably like to prescribe for the patient, depending on the ocular surface pathology which he or she is having here. So an ideal drop needs to manage all these components which you're seeing on your screens now here. So different demolition systems which we have in hand are cellulose-based, glycerin-based, emulsion-based here. And after we do go about environmental modifications and targeting treatment towards the particular ocular surface disease which is causative for or responsible for the dry eye, we would like to choose an artificial tear with emollients if you're tackling a meibomian gland disease. If you're having an evaporative dry eye disease, which is basic by the MGD, which is what most of us do tend to see in clinical practice, combine your artificial tears with other therapies such as warm compresses and the systemic and ocular medications. If it is an aqueous deficient dry eye disease, then you would probably want to include a lot of your tear replacements in combination or separately, in order to give a sufficient viscosity and tear volume for the ocular surface to function effectively. Mixed dry eyes, up to 70% of dry eyes in current scenarios are being mixed dry eyes, where you have an evaporative and an aqueous deficient component present here. So that's when a permutation and combination of these medications are probably going to work. So the way you would approach a patient is looking at his symptoms to sort of shortlist what is causing the problem. Is it a meibomian gland insufficiency? Is it a lipid insufficiency, or it's an aqueous insufficiency here? Understand the cellulose lubricants, the components of the polymers, which are either polysaccharide based or acrylic based. They can be HPMC, dextran, hyaluronic acid, which are the polysaccharides. Could be on CMC. The acrylic based are the PVP PEG components here. And each of them have their own have their own role cut out as increasing viscosity, enhancing lubrication, and increasing water retention, or acting as just wetting agents here. This is an interesting study which I always recommend you go back and look up at it. And when you looked at comfort index of the various viscosity enhancing agents, you did find that the comfort index of hyaluronic acid, HPMC, and CMC scored far above the other PVP PEG molecules here. So that's how a combination of these molecules really help when you have a combined dry eye disease here. They act collectively to increase the tear film thickness, they protect against desiccation, improve tear retention on the ocular surface, maintain the tear film thickness, and thereby help in promoting the globulate cell activities. Again, this is a particular chart to understand what are the various constituents of the active polymers which comprise the teardrops. And looking at preservatives present here, we have now moved away in most of our formulations from the hardcore damaging preservatives or the back-faced preservatives to more of the soft preservatives such as the polyquads or the SOCs, which are less damaging, especially when you need to use more frequent lubrications over a long period of time. And many of the mineral oil-based presentations are now available, which will help the tear retention over a long period of time. First line of therapies would be your simple hypermelose or the polyvinyl alcohol combinations here, which work well when the symptoms are episodic here, and they will help to stabilize the tear film. But a patient who's having damage beyond just episodic, then you would move on to paraffin-based or the other ones which contain like which contain formulations like HB-GOR. And the third line of sodium hyaluronate is when the I'll just take half a minute more here. And when the dry eye disease is most severe here. So the basic pointers towards decision making: when your tear osmolarity is normal, low viscosity artificial tear agents will suffice. When the hyperosmolarity is a particular factor affecting the tear homeostasis, you will need to combine them with anti-inflammatory agents. And when you find significant ocular surface damage in terms of corneal and conjunctival epithelial cell staining and damage, then you will need to resort to use of an agent which contains osmoprotective constituents to help tackle the hyperosmotic status. Thank you for your patient listening.
Of being able to concisely put all that together in the given time. We're going to move on. We're already receiving some questions from our audience, and that is always nice to have. It means they're getting engaged. I'm going to request Dr. Rajiv Mukherjee to give us his talk on MGD, and we can then take up the questions at the end of the session.
Thank you, Dr. Rishi. It's indeed a pleasure to be part of this course again. I'll be talking on meibomian gland dysfunction, a missed entity. Look at this 43-year-old female who was suffering with red eye irritation since 2 years and had taken around 8 ophthalmologist opinion in the last 2 years. And eventually the diagnosis came out to be acne rosacea. Taking the patient on slit lamp, we immediately noticed there's an element of dry eye. The meibomian glands were plugged and obstructed, and there are telangiectatic vessels on the posterior lid margin. Now, this untreated MGD, this was obviously a case of meibomian gland dysfunction. Untreated MGD eventually leads to or promotes evaporative dry eye, chronic discomfort with ocular surface damage. Now, this is what the normal meibum looks like. It's clear and small droplet of fluid, oily fluid that we notice, and they can be graded into grade 1, 2, 3, 4, which is a clear secretion that you see on the first slide on your left. It can be a cloudy secretion, which is grade 1, and it can be a cloudy with debris involved, which is grade 2, and grade 3 would be this toothpaste-like excretions that we see. Now, the eyelid margin features in meibomian gland dysfunctions would be thickening of the lid margins, as we see over here. The lid margins might be vascularized. There might be rounding off of the sharp posterior lid margin with hyperkeratization of the meibomian gland openings, and there might be lid margin telangiectasias. Lid margin changes might include posterior lid notches that you can see over here very clearly. There can be dimpling of the posterior lid margins, which is due to tissue absorption based on long-standing post-inflammatory changes. Advanced meibomian gland dysfunction will present with anterior migration of the mucocutaneous junction. There might be epithelial ridging due to mucosal absorption. There might be retroplacement of the meibomian gland orifices, though this is most commonly seen in advanced cicatrization form of meibomian gland dysfunction. Associated lid features will include anterior blepharitis, eyelid, eyelash loss or malposition, or demodex anterior blepharitis, as talked about previous speakers, with cylindrical dandruff. Now, one of the investigative tools which uses infrared photographic method for documentation of meibomian gland functionality or presence is the meibography. You can see these meibography. You can clearly see these grape-like clusters, ducts, and orifices are hyperluminescent, whereas acini are hypoilluminescent. You can clearly see on the slide on your right is that you can see a large area of meibomian gland dropout, which is suggestive of an advanced stage of the disease. And remember, once these glands go into the dropout stage, they can't be brought back. Lipid tear film interferometry is another tool, though not easily accessible to all. Clearly tells us the meibomian gland functionality, because eventually this lipid layer is the secretion of the meibomian glands, and altered meibum as well as decreased meibum will cause thinning of this lipid layer, causing evaporative dry eye. Now, what are the treatment options that the patient has? Warm compress stays as the mainstay of treatment. Warm compress along with mechanical lid massage and eyelid hygiene. There are various methods to do that. I don't have the luxury of time to go into the detail of each. One of the sophisticated ways would be to would be what LipiFlow does, which is the mechanical pressure along with thermal pulsations, which give a very good massage and opening up of meibomian gland function. Tear film, artificial lubricants are very commonly used in meibomian gland dysfunction, which not only takes care of the dry eye, underlying dry eye, but also dilutes the toxin and debris, and also the pro-inflammatory stimulus that comes along with it. Phospholipid supplementation or lipid supplementation to the tear film is pretty important, but it's unfortunately not available rampantly all across. But here you can see a video where there's phospholipid. Go back. Phospholipid spray being used here. It actually melts down and goes to the lid margin and then goes into the tear film. Azithromycin 1% drops are used very frequently and in fact recommended in the treatment of meibomian gland dysfunction. This not only acts as an anti-infective, but most importantly, it acts as an immunomodulator and anti-inflammatory agent, important in the treatment of meibomian gland dysfunction. Oral doxycycline or minocycline, 100 milligrams twice a day in case of doxy and 100 milligrams once a day in case of minocycline, can be used for around 2 months in meibomian gland dysfunction. Forced meibum expression is something that has been used for more than 80 years as an in-office procedure. And you can see here using a pedal and a pressure from a thumb, you can easily express out these toothpaste-like secretions. Intraductal probing has been one of the things that are being tried down. This is a video by Steve Maskin from Tampa, Florida, where he uses a 100 microns thick probe, 1 to 6 millimeters long, and he probes these duct orifices. And he claims to have a good success rate on the short-term period. Supplementation of diet with omega-3 fatty acids has also been considered in management of meibomian gland dysfunctions, but one good advice to our patients would be to avoid omega-6 rich foods like red meat. One thing that's been enunciated by the previous speakers is about Demodex infection. This actually coexists, especially in the elderly, with meibomian gland dysfunction. It can be easily diagnosed by plucking out one of these lashes with cylindrical dandruff to look under a light microscope, and you can easily find these worms moving around. Use of 50% tea tree oil, weekly lid margin scrubs also involve the eyebrows where you clean it with tea tree oil, also helps in such cases. So MGD perhaps is the most underappreciated disease, underdiagnosed disease, undertreated disease in the eye care worldwide. I guess we just have to use our finger, put some pressure on the lids, and we can see these expressions, and we immediately can diagnose these cases. Thank you. Thank you very much.
To your lovely slides and the way you were able to present it. I welcome Dr. Rohit Shetty here from Bangalore. There's going to be a little change in the order. Dr. Rohit is simultaneously conducting an important session alongside the adjoining hall. So I'm going to request him to share his screen and tell us about the inflammation and the inflammation connection with dry eye. And he has a whole host of his own work that I'm sure he'll be touching on, as well as telling us about the role of vitamin D3. Dr. Shetty, please.
Thank you, sir. Thank you for inviting me for this wonderful course. Been part of it for many, many years, and all the wonderful faculty that we've been part of. The inflammation connection between ocular surface and vitamin D3, no financial interest. It's been our journey of the time we started just as a clinical observation to time when we are looking at multiple areas of interest. And we have published ourselves around 30 odd papers linked to vitamin D itself for the last 10 years in all the best journal across. The last one was in ocular surface just a month back. So it's very important that we understand this relevance of vitamin D in the disease. There are many linked areas of vitamin D, not just in ophthalmology, but in different areas of medicine. In ophthalmology, goblet cell decretion, nociception, that means exaggerated response to everything, exaggerated response to washing your face, exaggerated response to just a wind or anything, change in your epithelial function, and more pro-inflammatory markers. These are all the group of people all across that just to show that a lot of people across the world have been looking at this seriously. But the two questions which always comes to the mind is, and this has been asked by everybody, whenever we started presenting it from 2010 onwards, India is vitamin deficient. Why aren't people getting it? Despite having normal level of vitamin, why do some people still develop dry eye disease? Could it be a factor? This is a very important question. Why recently, if you have seen the journal in NEJM, they spoke about vitamin D being a major factor in the patients who in the ICU, being patients who don't survive post-COVID, because there's one major factor involved is how your immunity is. There could be a relationship between the systemic and the local factors here and how the molecular things may control. Yeah, I'm saying that prevalence can be as high as 70%. So this is a paper which came 2 years back in IOBS, where we looked at all the markers the vitamin D does to change the ocular surface. Markers which cause change in Schirmer's, markers which cause discomfort. This is a very important thing. And if I want to put one thing about the vitamin D, the discomfort scale, what it does is very high. The markers which cause T-but changes and markers which cause confocal changes. This is a beautiful paper. Took 6 years for us to come out with this paper. Started in way back in 2013. And when we finished, it was 2018 or 19. So it's a huge paper, heavily cited, looking at every aspect of the vitamin D disease, from a pro-antiseptic to non-antiseptic factors, how it plays a role, and every aspect of the disease has been clearly discussed in this. I don't want to go into too deep into this. It just means that the tear film vitamin D is completely different from what you see in the blood. They're not the same. That is most important. I'll just going to show something recently, the last 2 years of work, because everything what you start has to keep going. There's never going to be an end to any of your work which you do. One of the things we looked at is genistein-controlled mechanism of hyperosmotic stress. We all talk about hyperosmolarity. The question is, what actually drives this hyperosmolarity? Dry eye, if you look at the Dew's definition, we say dry eye causes hyperosmolarity, or hyperosmolarity is related to dry eye. But the question is, what is the molecular mechanism of that hyperosmolarity? And this is something very, very big Journal of Clinical and Translation Science, which we published, where we looked at these factors. What we looked at is the vitamin D receptors. Every cornea has receptors, and you must have known that, like how you have now, everybody talks of the ACE2 receptors, of multiple TIMS2 receptors for COVID. You have receptors, VDR receptors on the cornea. These receptors on the cornea has to be active for it to function, to act like an immunomodulator. If your receptors are not functioning, then it doesn't work. So this is how a receptors look like. These are all very original work. And this is a staining of the receptors in a dry eye disease, which is low. So what does it mean? The receptors are extremely low on the surface. And this is what really helps in functioning of the vitamin. How did we check? We did a conjunctive impression cytology of the ocular surface to do this, and did some special staining to do that. And hyperosmotic environment actually drops the vitamin D. That means when you have inflammation or hyperosmotic changes, the vitamin D comes down. And what really brings it down? we figured out, this is the first time we figured out a receptor called TonyEBP. And these receptors are always high in dry eye disease. And this could be the future marker in your tears for hyperosmolarity. Now, when I speak about hyperosmolarity, we all know 320 millimoles per osmoliter. We used the machine didn't work, and we were unhappy. And there is no real way to look at hyperosmolarity check. How do you know this? This may not work at all because this is not reliable. Now, using this marker, which is also related to vitamin D, the TonyEBP would be a great marker to look at the vitamin D receptors. And this is an important slide. Increase in your calcitrol on the ocular surface, the TonyEBP reduces. That means increase your vitamin D, the TonyEBP reduces. That means in hyperosmolarity reduces. It's a very, very important point which needs to be done. And this is a very important form. That is why we need to have drops which contain calcitrol in the future, which we are working towards, which will improve or increase the BTR receptors and also reduce the TonyEBP, which is very responsible. In keratoconus, same thing. In the cone, the VDR is low. So molecular inflammation is there. So you have to treat it before you treat the keratoconus. To summarize, vitamin D supplement reduces the hyperosmolarity. It looks at reducing the TonyEBP, improves the vitamin D receptors. It changes the inflammatory markers. And all this can be controlled by cholesterol-based drops of the future. This is my vision because there is a huge potential for this as a research, and this is something which we want to approach. Thank you.
Well, thank you so much, Rohit. As always, you always come up with something new and with something innovative, and we greatly appreciate that. I have a couple of quick questions. I know you probably...
No, sir, I can take questions. I'm not in a hurry.
So I'll be happy if there are questions coming in from others as well. But I had two questions, and of course, this relates to the inflammation, and I can see how closely the keratoconus pathophysiology is also linked to similar inflammatory events happening in the cornea. So my question was, in the absence of a local vitamin D being available, how important is the role of systemic vitamin D? So that would be my first question. And what would be the ideal way to go about it? Should we measure vitamin Ds and then give the patients, or shall we just give them, a bolus or something like that?
So, sir, what happens is when your vitamin D is in single digits, which is very low, less than 10, you know that your vitamin D receptors on your corneal surface are also shut down. So if you start giving him oral vitamin D, the vitamin D receptors doesn't open up. You need a bolus. So when you infuse a bolus injection, that's when you need to talk to a physician, because many physicians don't believe in this concept because they think that some people are believers, some people are non-believers. But the science is showing the clear path now. When I used to present in your talk, the last 6 slides were never there.
Yes.
And these are all, like I keep adding slides as we move on. And we have had 3 papers on this subject from the time we had last year. See, what it means is, when you give an infusion bolus, you open up the receptors. It's a pump mechanism. And when they open up, the receptors work like an immunomodulator effect. Then the vitamins, what you give, goes and binds to it. So even if you put drops on the eye, if the receptors are not functioning, you put a drop, there's nothing for it to actually bind. So if you have circulating vitamins, but no receptors, it doesn't work. That is why you may have a completely healthy vitamin D, but still it will not function. You may have around 15 or 18. You say, I'm still normal. But your vitamin D receptors on the surface is bad. Because we have realized with this paper that vitamin D receptors controls the hyperosmolarity. The TonyEBP, what I mentioned, that is something which is going to be a marker for hyperosmolarity, which you can detect from tears. That's the next wave of work which we want to do on that. So infusion is a good one, and I use the physician to do it because many times we don't know how much to infuse because this can when hypervitaminosis ends up in kidney stones. I don't want to get into that zone. But I have a physician who believes in it, and for vitamin D work, you need to have a physician who understands what you're saying.
Got it. So a bolus like 600,000 units,
Yes.
or so
Yeah,
injectable or orally is something that you'd recommend?
Orally is what I recommend when it's in the mid line, when you are between 20 and 30 and all that. And keratoconus definitely yes, because it's linked to scarring. When you don't have vitamin D, more receptors there, hyperosmolarity is high, healing is different, scarring is there. So it's very important to look at it from a PRK perspective also. Like I said, the work is last 11 years. So every year brings in a new angle so that we keep adding to the knowledge base. And this knowledge base bridges the data gap what we have been having. From the time I started speaking in your course, when I was to just give vitamin D, it works well, and nobody believed.
It's wonderful. And my next question, actually, Dr. Vanati mentioned about preservatives. And I know you've done a lot of work on inflammation. So I was wondering if, I'm sure the preservatives also do their toxic effects or produce their toxic effects through an inflammatory mechanism in the end. So which preservatives do you think are the ones that are the biggest culprits and which are relatively more forgiving? Any work based on these inflammatory things that you're doing research?
So what happens is if you use a preservative-free or preservative-filled drops on a good ocular surface, it hardly does anything on the surface, whether you use back or anything. The challenge comes is when you use it on a...
Yes. Yes, Tanvi?
Doctors, actually, we are exceeding the time.
We are exceeding
have
the
one
time?
more speaker to go.
Yes, we have one more speaker.
Can you
Okay.
proceed?
All right. Then
Yeah.
we'll move on. We'll request Dr. Rajesh Sinha to give us his talk.
Yeah.
Is Rajesh here? Rajesh?
Yeah,
Yes, sir.
And,
He is there in the hall.
Rajesh, please.
Thank you so much, sir.
Thank you, Tanvi.
Well, it was really nice. I was listening to Dr. Rohit about his studies, and I would have loved to listen more about all those, but definitely we'll have some more time on this. I'll be talking about post-surgical ocular homeostasis, and there are certain issues after successful surgery. Like you want, if you're doing a cataract surgery, you want a good visual outcome. So IOL should be well centered. Retinal surgery, you want the retina to be flat. Glaucoma surgery, you want the IOP to be normal. LASIK flap should be fine. So all these things you want as a surgeon. But the patient not only wants the vision, but also wants comforts. And symptoms like irritation, redness, foreign body sensation post-surgically is really very disturbing. And the cause of this symptom is a disturbed ocular surface homeostasis, and that is because of inadequate ocular surface hydration. Now, LASIK can cause dry eye by reducing the corneal sensation, by cutting the nerves, and some patients might be having a pre-existing dry eye. This is the neuronal loop that is there. When you do LASIK, you cut the nerves and these sensations don't travel to the brain, and then the secretomotor nerve impulses, they don't come to the lacrimal gland, and that's how the tear secretion reduces. And this is one survey which was conducted long back, and they found out that 21% of all those who are dissatisfied due to dry eye. So 1 out of 5 dissatisfied patients are because of dry eye. Cataract surgery can also lead to dry eye because of so many factors, because there are some preoperative factors like cataract patient population is old, has a high chance of preoperative dry eye, perimenopausal females, MGD, coexisting glaucoma, taking anti-glaucoma medication. And then when you do cataract surgery, you alter the corneal curvature, cut the nerves. There can be, you want to have the best results, so you want an arcuate, etc. Incision, which can further, cut the nerves, and all these factors can lead to dry eye. Then following glaucoma, again, there are various factors like you use antimitotic agent. There can be blebs that can cause disruption of the tear film tear surface. And just hold on. Hello. Sir, आप बता दीजिए. सर कुछ भी कर सकते हैं सर. Oops. So, when following retinal surgery, there can be corneal surface disruption. The retinal surgeons due respect to them, but they, debride the epithelium. Sometimes the conjunctiva is also damaged. There's a study on phototoxicity of microscope also. Then this study wherein they showed that those patients wherein silicone oil was used, they had more chance of ocular surface disorder. And of course, drug toxicity can also lead to ocular surface disorder. And this is a terminology which is ocular OHHQ, ocular surface, ocular homeostasis quotient. So the things in the numerator, if they are high, then the value of OHHQ is high, and that is better as far as the comfort of the person is concerned. The management depends heavily on, of course, lubricants till date. And of course, there are many new things coming up, as was being discussed just now by Dr. Rohit Shetty also, regarding use of vitamin D. And then, of course, we use the lubricants. Amongst the lubricants, we have carboxymethyl cellulose, hyaluronic acid, and PVA, PVP combination, HP GOR combination. Then we have drugs to reduce inflammation like topical steroids, cyclosporin, and of course, doxycycline and omega-3 fatty acids. So, but these are some of the basic things about the post-surgical dry eye. But there are many emerging concepts, and one of the concepts that has, a couple of concepts have been discussed earlier. And one more concept is that UV rays causes apoptosis of ocular surface, and that results in ocular surface disorder. And chloroquine, which is an anti-malarial drug, by systemic use, accidentally people found out that it helped in dry eye and Sjogren's syndrome, and that's when people started thinking of use of topical chloroquine. And chloroquine, what it does, that it inhibits the metalloprotease release, and this may control apoptotic inflammatory cascade. And chloroquine provides photoprotection from UV rays. There have been experimental studies, there have been animal studies, as well as the human studies, to show the safety and efficacy of chloroquine in terms of reduction of apoptosis, in terms of reduction of inflammation, and in terms of improvement of symptoms of dry eye. And so even at our center, we have done a study at RP Center done by Professor Tital et al. And found out that topical chloroquine is a useful adjunct to topical lubricant in management of dry eye disease, because it improved the parameters related to dry eye investigations. And a couple of studies done at Narayan Netralaya also by Dr. Rohit Shetty. Then I'll just move on to some newer polymers like leftegrast and ribamipide. Now, leftegrast is something which is not available in India, but it is a lymphocyte function associated antigen antagonist, which prevents the adhesion, activation, migration, and proliferation of lymphocytes, which ultimately lead to cytokine secretion, cell destruction, and self-amplification of the inflammatory immune response that further aggravates symptoms of dry eye disease. Now, it is not available, the dose, it is just like cyclosporin. Basically, it reduces the inflammation, and it is like cyclosporin. And since it is not available in India, we don't have a personal experience, but it is available in US, and the cost is more or less the same as cyclosporin. And but so far, no studies have been done comparing leftegrast to cyclosporin, and no study has been done to see the additive effect of leftegrast. Then ribamipide is another polymer which I would like to mention, which is a mucin secretagogue, and it is really useful in it contributes to stabilization of the tear fluid by serving as a scaffold for the localization of mucin. It prevents the damage to the microvilli, and that is an important thing. This is one thing which states that ribamipide treatment damage to microvilli. Dr. Rishi, do I have a minute or two?
Yes, you have a couple of minutes, Rajesh, and
Yeah.
then we have Vanati last.
Yeah. Okay. So ribamipide, as I was mentioning, that it not only protects the microvilli, it increases the proliferation and thereby density of goblet cells as well. And that is how it protects the ocular surface. So it ensures firm adhesion and good stability of tear film over the ocular surface. And I'll just skip all this and I will show this that, ribamipide not only stabilizes tear film, it proliferates goblet cells, it increases mucin production, it decreases tear hyperosmolarity, it decreases inflammatory mediators. So it has a 360-degree benefit in the management of dry eye syndrome, and that is quite useful. Now, a couple of studies have done, and human studies as well as animal studies, which have shown that it improves the symptoms related to dry eye and improves the repair of the ocular surface and health of ocular surface. And not only in dry eye, but it also helps in certain allergic conjunctivitis like VKCs or AKCs, wherein it reduces the giant papillae and thereby improves the health of the ocular surface. So, and as far as dosage is concerned, it is instilled 1 drop at a time, 4 times daily for 4 weeks. And it is reasonably safe. And that's why this polymer, which is really coming up quite fast and is being accepted by many people, is really very beneficial for protecting the ocular surface. So in conclusion, I would like to say that, in post-surgical dry eye, you have a whole lot of things wherein, it starts with a preservative-free lubricant to, improve the symptoms. Then, of course, topical cyclosporin or leftegras or topical steroid to reduce the inflammation. Of course, patients might be having MGD. So omega-3 fatty acids, although there is one study which states that it doesn't have much benefit, but many of the studies have shown that it does have some benefit in MGD, and as mentioned by Dr. Rajiv Mukherjee. To prevent apoptosis, topical chloroquine phosphate has been used, and topical ribamapide is also an option. So we do have some polymers, we do have some additive agents, we do have many other things, and I still feel that we still have to know a lot more to actually understand the real mechanism of how things happen and what all are the newer stuffs that can help in improving the symptoms related to dry eye as well as health of the surface.
Thank you, Rajesh. Thank you very much, Dr. Vanati. We have the last presentation, but not the least, on cyclosporin. So please go ahead and let us have your talk, please.
Thank you, Dr. Rishi. I guess we just have a couple of minutes more, so I'll just touch upon the salient features in the role of cyclosporin in ocular surface disease management. I have no financial interest here. So we are looking at the ocular surface epithelial damage induced by the hyperosmolarity tears, primarily also adding on to the surface inflammation, which results because of the ICAM molecules, the T-cell infiltrations causing interleukin-induced damage, matrix metalloproteinases, and apoptosis being the primarily important features of the ocular surface inflammation. This is a nice chart which sort of intercorrelates the ocular surface staining due to epithelial cell damage, the tear breakup time, the Schirmer's, and how the hyperosmolarity are interlinked here. So how does cyclosporin really help? This is a molecule which basically acts as a T-cell inhibitor and prevents the release of interleukin-2, thereby decreasing the ocular surface inflammation and acting as an immune modulator here. And which are the cases in which cyclosporin is going to be helpful here? We'll have to understand that cyclosporin is helpful when there is adequate amount of aqueous secretion and the lacrimal glands are still functioning. So it's not going to be helpful in cases in severe dry eye disease where you have got immune mediated, you've got inflammatory damage to the glandular adnexa, which are involved in the tear film dynamics here. It helps where there is a certain amount of aqueous secretion available here, and these are the potential candidates in which it's going to be helpful in managing. So it could be helpful in mild to moderate dry eye disease with contact lens intolerant patients, chronic VKCs, allergic eye disease and SL case are the cases which are going to benefit. And there is clinical and experimental evidence that use of topical cyclosporin as an immune modulator does help in improvement of the subepithelial corneal nerve fiber plexus here following cyclosporin therapy here. I think tacrolimus now is now proving to be a more efficient immune modulator in comparison to cyclosporin, except that the ocular surface stinging effects are perhaps much more than cyclosporin. So we do use or resort to using tacrolimus over the lid application, which does work and help in reducing the ocular surface induced inflammation. Thank you.
Thanks very much, Vanati. That was short and very sweet, and you finished well within the allocated time. So thank you for highlighting the important areas. I thank all my faculty. I don't think there's much time left for us to have many questions. There are some questions that have popped up on the screen, though. One is, of course, the question of what is the treatment of lice moving around the eyelash roots? If Dr. Rajiv would like to answer that. And what is the role of vitamin D if in keratoconus if it continues to progress after cross-linking? Maybe Dr. Rohit would shed light on these two questions. You have about 30 seconds each before we wind up.
My answer is yes. Check for it and treat it before cross-linking, because you will see a huge difference, not only in the outcome, but also the haze and other factors up there.
Great. Thank you so much, Rohit. Rajiv?
We treat it usually with local 50% tree tree oil application at the lid margins twice a day. And also you need to remember to treat the eyebrows, hair around the eyebrows. Systemically, people have tried ivermectin, but there's no one answer to this. There have been various drugs, none of them are 100% effective, but yes, to identify and start treating with these two simple measures would be a good answer.
Thank you so much. Thanks, Rajiv. So we will conclude the session with a vote of thanks to all the lovely faculty and their wonderful talks, and to the scientific committee for giving us this opportunity to be here again. And we certainly hope to see you all next year. And so goodbye. I think it's pretty much the last session.
Thank you so much, our chairperson, our honorable chairperson, Dr. Rishi Mohan, and all the informative speakers. Thank you so much for enlightening this session. Have a nice day ahead.
Thank you, Tanvi.
Thank you.
Thank you, everyone.